call it echocardiography. ده اللي احنا بنسميه اسمها science. So echo ultrasound, they call it radiology for other. It's basically it's ultrasound, but the other name we call it echocardiography. And CT, somebody mentioned CT, as well as MRI and the nuclear cardiology. So we'll go through them one by one. Chest X-ray is very important, simple, with low radiation, giving a lot of information for cardiopulmonary. And I know this clear to you. So as you can see, the heart in the center and toward the left side. You need to know the anatomy and the position of each one in X-ray to be able to make a diagnosis in case if you have any chamber enlargement or vessel dilatation. Along with also if you have calcification. So what's this? This is the apex, the heart coming here. So this is the left ventricle. And what's this here? This is right atrium. So, and up coming from here is the SVC, and from down here is the IVC, which you see the border here, just this. So the IVC, SVC coming over drainage into the right atrium. And importantly, to know the pulmonary trunk and the aorta. So the aortic arch comes this way, and the pulmonary trunk. These are very important findings in cardiology. The other thing is that to know what is the size of the heart and to make sure if there is any cardiomegaly or not. And I'm going to show you some pictures. So there are two types of straight plane X-ray. So we do it either AP or PA. So in AP, there is some difference compared to PA. Which one is the ideal one?
PA.
PA. We do this sometimes in patients, especially hospitalized patients in bed that we cannot mobilize. But however, the PA is better projection. What are the difference? So you might get a question for the difference between the PA and AP. So, sorry? Okay. So the scapula, as noticed here, see the scapula here is a outfield view. What is here? Still you can see the scapula. The clavicle position, you see the PA view. What is the clavicle hand compared to this one? And the other thing is the angle. And importantly here to see the cardiomegaly. It's difficult to comment on cardiomegaly in AP view because it's usually larger than usual. So how can I comment about cardiomegaly? It's more than 50% in PA view or 60% in AP view. So we measure the from the edge to edge here and the diameter of the heart. So who can tell me what the difference between these two X-rays? These are the same X-ray. Excellent. So which one is inhalation? The other side. So you have to ask the patient here, because there is, as you can see here, this one blood diaphragm is up, and you see the lung tissue is very clear of the exhaled one. So sometimes you misdiagnose this patient with either atelectasis and congestion. About this. What is the pacemaker? There are leads. You can see there are leads. Probably ECG leads. So you see 1, 2, 3 here. And 4 also here. There is one here. So this ECG leads. What else? heart size. Yes, you don't see it very well, to be honest. Here, this is the heart from here to here. This is the edge. Something more important, very critical. Fine. Sorry? No, more critical than this. So just can you raise your hand if you want to answer, please? Just I can hear you. Excellent. So this is aortic dissection. See this from here to here. Let's go back. You remember I told you the aorta is here. So this is the mediastinum. This one and this one. This is normal structure. But in case of dissection and patient come to emergency with chest pain, so first thing you have to do is X-ray. You see this is dissection. And this is critical findings and emergency situation. So we call it dilatation, here very clear, the mediastinum. About this. Sorry. So what do you think about heart here? Cardiomegaly, excellent. And
Pneumonia.
what do you think about the lung tissue here?
Is it pneumonia?
No? Okay. Yes. Yes. So there is, as you can see, there is interstitial infiltration here, bilaterally, and this is most likely congestion. You see localization of the vessel here, and there is a lot of congestion. Okay. And how about this one? Pneumothorax? What's it? Hemothorax. Why is it hemothorax? So, how do you differentiate between fluid?
If it's fluid, the picture will present the area.
So this is a fluid. So it's either blood or just clear fluid. So this is, we call this pleural effusion. Okay, pleural effusion. So pleural effusion cannot differentiate what type of this in X-ray. Never. So this is pleural effusion. And this is a classic when you see a patient with right side pleural effusion and suspicion of cardiomegaly here. This is typical for what? Heart failure. Heart failure. So in heart failure, they commonly come with right-sided pleural effusion. And this is exam question. So this is very common. And you cannot comment on type of fluid on X-ray. Okay, so second, any question on X-ray? Let's go for echo. So echo is probably the most common test that we do in cardiology. It's a very informative test, easy to do. Well, we'll say like relatively easy to do. And this is mostly operator dependent. There is no radiation in echo because it's ultrasound. There is no contrast. However, we might give contrast. We call it contrast. It's not contrast. It is just a material that go away without any effect on kidney or other organ. And sometimes we give bubble. We mix saline with air, just 1 ml of air, and inject it in certain situations. So it's very safe procedure, easy, quick, very available, and very informative, non-invasive test. Okay, so what's the benefit of echo in cardiology? What we do, or why we do echo? There are a couple of things to assess you. Go ahead.
Check for the valves.
Okay, excellent. Mm-hmm. Go ahead.
Assist the function.
Function. Sorry, one here. Okay, so basically we do it for function, left ventricular function, right ventricular function, assist cardiac chamber, left ventricle, right atrium, left atrium, and assessment of the valves either it's stenosis or regurgitation, calcification too. Is there any congenital anomalies or something, any pericardial effusion, pericardial constriction or restrictive cardiomyopathy? It's very informative test and easy and available. So a short exam time. Do you know how much take full study echo? How long? It's actually 45 minutes to 1 hour. So it's at this range. And it's bedside test, no radiation as I mentioned, and accurate evaluation for all motion and valves. Okay, so what's this? So this is parasternal view that we put the probe here, and one patient on the left lateral position, and we look here to the aorta, the right ventricle. We just see the RVOT or right ventricular outflow tract here. This is what you see in parasternal window. You don't see the whole right ventricle. And this is the interventricular septum, and this is the posterior wall or infralateral wall. So this is what we see on parasternal view. So this, what did you notice anything here? Normal. So you see this. This is pericardial effusion. You should not see this. It should be something like that up here. So there is a pericardial effusion here. Left ventricular function looks fine. And again, so this is the left ventricle in short axis. We cut the heart in short axis. And you see here, the contractility of the ventricle and pericardial effusion again. First one. So this is the septum here, the interventricular septum. This is the posterior wall, and this is the right ventricle, and this is the left ventricle here. So this is left ventricular cavity. This is right ventricular cavity, but this is just the upper part of the right ventricle. So we call it RVOT, right ventricular outflow tract. It's like this here. And this is the aorta, ascending aorta. So the aortic valve is here, and this is the ascending aorta. What we see here is that this is the pericardium, this is the parietal layer, and this is the visceral layer. So you see there is fluid in the pericardium here. So that's why we call it pericardial effusion. Okay, again, here, see the pericardial effusion, how big is this? This is the apical port chamber. There's very clear pericardial effusion again, and there is collapse of right ventricle. This patient might be in tamponade, so we need to tap the patient and clear the fluid to avoid collapse. So what's this? This is we just zoom on the left ventricular outflow tract, the aortic valve here, and you can see there is regurgitation. You see this color here. So during the diastole, this one, it's coming back. So this is aortic regurgitation. So this one has a color, abnormal color here. You can see. Again here. This one from the aorta. Sorry again. This one? No, so you mean this one? This one you should not see anything coming back. You should not see anything coming back here, okay? So this color here should be all the same as this blue color, but you see this mosaic color here, this is abnormal. So this color is abnormal. This one is okay, because you see the scale. Anything going up here is going to be red. Anything coming down is going to be blue. So if you have a mosaic color like this, so this is turbulence flow. Okay, same as here. So this is the interventricular septum here. This one, and you see there's something crossing the septum. So what's this? So this is septum, and there is current crossing the septum. Sorry? Anything? Any clue? So you see the color crossing the interventricular septum. There is a defect. There is a defect. So there is something abnormal. So we call it ventricular septal defect. Yes. Normal echo. So, unfortunate, I don't have a good one, but let me go back. Normally you see LV, RV, there is no fusion. This is what you see. And you see the septum here is intact. Okay. Here there is a fusion, otherwise nothing abnormal. So this is the left ventricle, right ventricle here, left atrium and right atrium. But the abnormal thing is this one. Okay, this is aortic dissection because the dilated aorta is in the aorta. This is the flap. You see this one. This is abnormal. This one, and this is the normal wall, and this is a flap. Okay, I'm just so this is the contrast that we give on echo. There is a shunt or AST between the chambers. You inject contrast on the right side through the vein here, and comes to the right side. This is the right side of the heart. You see it's fully opacified, and there is something crossing from here going to the side. A normal person, this should not happen. You should not see anything here on this side. It should be black. But there is a certain defect. So this is left ventricle. This is the right ventricle here. Don't worry about these views. I'm not gonna come your exam. Just I want to show you what is the application. What are the applications of echo? Okay. Don't worry about that. Nobody will ask about this. But this is just to show you the application of echo. So this one, we're injecting contrast in this and showing the atrial septal defect because of bubble crossing from the right side to the left side. Okay, so this is bicuspid aortic valve. So as we mentioned, it's assessment of the valves. So basically, echo is to assess the left ventricular function, right ventricular function, and atrial and ventricular size, as well as valves. These are the most important application along with pericardial effusion and ascending aorta. Do you get questions on echo in the exam? It's not. Yeah, but you don't have clips like this. Yeah, that's why. So don't worry about it. I'm just showing it for the application of echo. Any question on echo? Okay, so we'll move to the third one, which is cardiac CT. So cardiac CT is a very important tool for cardiopulmonary. We know the chest CT is well established for a long time. However, the cardiac CT, especially for coronaries, is just something that emerged recently. I would say like a couple of 10, 15 years. And actually, how we do the CT. So we put the patient here, the table, and we connect him with the cannula to give him a contrast. So most patients go to cardiac study, we give them contrast, which is iodinized contrast, small amount of iodinated contrast. And this table will move. This table will move. This is the gantry. The source of radiation comes from here. So there are dual source. Dual source means there are two radiation source come to the patient to minimize time inside the CT scan. This table will move. So we take cuts of the heart and chest during movement of the table. This movement is very fast now. We can take full study of the heart within 5 seconds, or even less than this. So we do it in very controlled heart rate, very fast test, very informative, and radiation is not very high as before because of new scanners. So what are the indications? Why we do cardiac CT? Okay, excellent. So check the arteries. There is any coronary anomalies? Do you know any coronary anomalies? So coronary anomalies actually basically it's either the origin of the coronary artery comes from abnormal place. You know, we know that we have two main coronary, left main and right coronary artery. Left main branching into two vessels, which is LCX and LAD, left anterior descending artery and left circumflex artery. And then the LAD go through the interventricular septum, the LCX goes through the groove, and the RCA go through the interventricular groove on the right side. Sometimes you see anomalous coronary artery, that's the left main comes from the right side. So the CT is the best test to assess this anomaly. For preoperative assessment, coronary artery disease, as you mentioned, pulmonary veins, aortic disease, ascending aorta or aneurysm dissection, it's the gold standard for dissection. And aortic valve disease, pre-procedure, especially nowadays we do TAVI and robotic surgery for cardioembolic or cardiopulmonary embolism and congenital heart diseases. It's very important before sending your patient to CT to know if the patient pregnant, is there any presence of contraindication to contrast media, because some people are very allergic and the patient can collapse in the scanner. Renal impairment, why? Because the contrast is nephrotoxic. So we have to be careful with those patients. They are well hydrated before sending them to a CT scan. If their GFR is less than 30, should not do it. And bronchospastic disease, why? It's important. Some people have allergy to that and they develop severe bronchial asthma attack. Severe aortic valve, why? Especially in cardiac, we give nitroglycerin, we give beta blocker, so we decrease the outflow, so the patient might again collapse because of low outflow. And we need to check the body weight, so the patient able to hold breath, because when you breathe, the patient breathes during the scanning, so you cannot see anything. It's going to be very messy images, and you cannot evaluate the cardiac chamber and coronaries. The scanning should happen while the patient holding the breath. Okay, so heart rate control is very important, and to assess if there's any contraindication to beta blocker. This is real images, 3D reconstruction. So the new scanners now and new softwares, post-processing, we can do 3D. So this is the posterior, and this is the anterior. As you can see, this is left ventricle here. There is LAD, and right ventricle, right atrial appendage here, left atrial appendage, and this is pulmonary artery, and this is aorta. On the other side, there is coronary sinus, yes? Again?
What is nitroglycerin?
Nitroglycerin. Something is a vasodilator. So this you remember, or if you see some patient having tablet under the tongue, this is nitroglycerin, cardiac patient. It's vasodilate the vessel, make vessels big. Okay, so This is the posterior side, left ventricle, right ventricle, coronary sinus, left atrium and right atrium. So this is what you see when you do cardiac CT. So inject contrast, goes to the right side and then go to the left side, from left side come to the aorta, and from aorta you see the coronary artery, and you make a diagnosis of there is any coronary artery disease, aortic disease, or left ventricle. Okay. So how we do it, as I mentioned to you, we put the patient here on the table, and we connect him to ECG, and inject him with contrast and scan him. So usually patient holding his breath, and we take it through the cardiac cycle. So we have to specify what cycle, what is the part of the cycle that the cardiac is static, mostly is static. You know which part of the cycle? So this is T wave. Let's say start from this. This is P wave, QRS complex, and this is T wave. Okay, so in diastole, so this is systolic phase from here to here, the QRS and T, systole, and this is diastole. The static phase, the heart is not moving, or less motion of the heart in mid-diastole. So what we do, we keep the patient in the scanner and scan him at this level, from here, for example, to here, from like 60% to 80% of cardiac cycle, to allow to or minimize the motion artifact. Because if we scan during systole, the heart is moving, the coronary artery will not be seen well because of motion artifact. Okay, so the anatomy here is much easier than echo. So this is the left ventricle. This is the left atrium. So what between the left ventricle and the atrium? Mitral valve. You can see this is the leaflet, and this is another leaflet, anterior and posterior leaflet. This is the septum, and this is the right side. So this is tricuspid valve, and this is the right atrium. This one is the right ventricle, and this is the pericardium. You see a thin line here. This is the pericardium. Again, so this is 4-chamber. This is 2-chamber view. So we're seeing the left ventricle only. We're seeing it from the septum to the lateral wall. So this is anterior wall, and this is the inferior wall. This is the apex. Here is what? Left atrium, and this one is left atrial appendage. This is 3-chamber. 3-chamber is seeing the left ventricle and LVOT, along with the aorta. So this is the aortic valve here. This is the left ventricular outflow tract, and this is the anterior mitral leaflet, this posterior mitral leaflet. This is the left atrium, and this is the right ventricle here at the ventricular septum. This is short axis in cardiac CT. So we see the left ventricle and right ventricle here. So this is basal slice, and this is mid ventricle, and this is the apex. CT, we can have it static images, and we can have it moving images. So you can assess the cardiac while it's moving in CT, like echo. But the issue with that is giving more radiation, because we're recording the whole cycle of the heart, systole and diastole. So we like to minimize the radiation to the patient. So we just specify what we want. If we need function, we have to do full cycle. Anybody can tell what's this? Excellent. So this is 2-chamber, and you can see this lady here, go to the apex, and there is a stent here which is patent. You can see the contrast inside it. How about this? Difficult one. So this is axial view, actually going from up down. I will orient you here. This is the right RVOT, this is aorta, this is the left atrial appendage, and this is pulmonary vein. This one is the left main disease, or let's say left main artery with some mild disease. And this is the ramus intermedius artery, and this is LCX, left circumflex artery. And what's this? So left main giving 2 main branches, LAD. Okay, So LAD, left anterior descending artery. What do you see here? This LAD. It's occluded LAD disease. So it should be like this. So this is occluded LAD. Proximal LAD is occluded till the first branch, which is diagonal branch. So this is just example how or what's the utilization of CT or cardiac CT. So anomalies, we say assessment of coronary artery disease, assessment of the chambers, function sometimes if we need it, and the vessels, pulmonary veins, especially for AP studies and ablation. Okay, so fourth modality that we use is the nuclear cardiology. We use the RNA or MUGA scan. It has so many names. So it's actually the idea behind the nuclear is we're giving the patient a tracer, and we taking this tracer with the machine like a CT. It's recording the tracer coming out from the body to the machine and taking, we call this counts. So you know the uranium, we are not using uranium in nuclear cardiology, but اللي يسمونه المشع, like radioactive iodine, for example, we use it in medical for medical application. This radiation is not dangerous. However, it has some. You have to be cautious when you use it for the patient. Based on age, the dose that you give to the patient, because still it's radiation, and it can carry a risk of cancer. So we use very small doses that likely does not affect much the cells. So in this patient, in this aspect, so in RNA, SPECT or PET, we're using each one different tracers. So why? Because it depends what you want on this. Any idea about a nuclear scan in cardiology? You know what we give and what are tracers? Any name tracer that we use? No clue. So we use technetium SPECT mainly, and we use in PET, which is positron emission tomography. We use the rubidium, ammonia. These are the main two. And in RNA, we use technetium too. RNA is for, what is RNA? It's actually, it's not very clear. This is the gold standard test for assessment of the left ventricular function. We use this a lot in oncology patients. After giving them chemotherapy to follow up the patient to assess left ventricular function, we do this test to assess the left ventricular function. So this is the left ventricle here, and this is the right ventricle. It's basically, you don't see the ventricle, you see the blood inside the ventricle. So we're labeling them with technetium, and then you assess the function here. Again, you see it here. So this is the left ventricle, and we contour the diastole and systole, and we get the ejection fraction. This is very accurate measurement for left ventricular function. Okay, same. So what are the limitations? As we say, there is a radiation. We see only the function, nothing else other than function in this. So the nuclear imaging, SPECT, we assess the function of the heart as well as the perfusion. If there is any ischemia. So SPECT or nuclear imaging used to assess for ischemia mainly, and can help function too. This is the function. This should move, so you can assess the in systole and in diastole, and you get the LV function from it. So what are the advantage of MPI? MPI is myocardial perfusion imaging. We call it MPI. It's not affected by patient habitus. The patient is obese. We can use PET, for example. We can assess the wall motion at rest and stress, and we can obtain the perfusion. Still have gradation, and So this is typical example of SPECT. This is what we see. We do it every day in our hospital. We do these images. You know what it looks like. See, like a donut shape. So we cut it from base to the apex. So we cut the heart. Here is the base, going down to the apex. This is the apex. And this is the septal wall, lateral wall, the anterior wall, and the inferior wall. We see if there is any perfusion defect. And compared to the rest, this is stress and this is rest. We stress the patient, we ask the patient to exercise or give him injection to stress him. What is the injection that we give to the patient for stress? Medication? No. Dipyridamole or Percentine. Percentine stress or dipyridamole. I think this is important to know. Percentine or dipyridamole to stress the patient cannot exercise. How can we take the images? So we have to give him medication to stress him. So either to give him dipyridamole, adenosine, pegadrozone, or butamine. These are medications that we give. So we give either adenosine, dipyridamole, pegadrozone, or butamine. And compare stress part to rest. There is a defect in the stress and normal rest, that means ischemia. There is defect in both, same, going to be scar. There is no defect, is normal. Okay. MRI. So MRI is a gold standard to assess heart function, especially cardiac, left ventricle, right ventricle. It is comparable to MUGA scan or RNA scan in assessment of left ventricular function, and it's better in all modalities, better than all modalities in assessment of the right ventricular volume and function. It has high spatial resolution. And excellent reproducibility means if any of you do this MRI and contour it, you give the same result of all of you. So it is very accurate test. So what we do with MRI, these are the most important indication or to look for MRI: morphology, perfusion, viability, and tissue characterization, and blood flow. Probably this is the last slide. So you know what these colors are. So this is MRI. MRI is very important test in cardiology, and it is progressing very fast, and it's becoming gold standard for most of diseases. There are sequences during MRI that just take about 1 hour. So we do anatomy, we do function, and we assess the valves, assess the flow, and look for tissue characterization. Tissue is very important. Sometimes you don't even need to do biopsy because you can make sure that the diagnosis is clear from MRI. So this is T1. You know T1 and T2? Okay, good. So T1 weighted images. You see, this is the left ventricle here, and this is the right ventricle, and this is the left atrium, and this is aorta. So we see the anatomy and fat. This is fat here. And T2, we see also anatomy. This is short axis. This one is the left ventricle. This one is the right ventricle. And you see the anatomy and as well as fat. The most important thing in T2 in MRI is edema, seeing the inflammation, or looking for any acute events like myocardial infarction. Late gadolinium enhancement, probably the most important sequence in MRI. So LGE, so basically we give contrast. Contrast in MRI is different than CT. So we give it gadolinium. Gadolinium goes to the body and trap in scar area or acute inflammatory myocytes damage, and you can see it imaged here. This one is normal. You see the black color here, all normal, but this is abnormal. There is gadolinium here, means there is scar or inflammation here. And depends on where is it, you can make a diagnosis. I will not go deep on this, but this, for example, this one is myocarditis. Okay, so T1 mapping, T2 mapping, they need to know much about it. It's a new things, but it's also very helpful in assessing fibrosis, edema, and T2 mapping in iron overload and edema as well. This is very important to check for iron overload. Very simple test, T2 star, without giving patient anything. We just assess how much iron in the myocardium. Extracellular volume, also mapping, we can check for certain diseases like amyloidosis and Fabry disease. Okay, so why MRI has limitation? Because it's very expensive. One test of MRI costs ranging from 6,000 to 8,000 riyal for cardiac, so it's very expensive and limited availability. You need a lot of technologists, trained physician to do it and interpret it, as well as there is some certain contraindication. However, there are most of the new ICDs and pacemakers are compatible with MRI. You can do MRI with them. Okay, that's it. Any questions?
Thank you.